So just quick blanket statement, big thank you guys to all that you do. We know how big the ask is. We know how much you guys precept, and the welcoming that you do to our new team members is huge. You guys are the face of our unit and the reason that, our team members have a positive experience and end up falling in love with the patient population and learning about the NICU. So truly your hard work and dedication does not go unnoticed by us. We couldn't do this without you, and we appreciate all that you do. So preceptor responsibilities. Really just overall kind of a general, blanket statement of just staying connected, with us and staying connected with your patients, your orientees, but also your mentors. We really just want to hear from you. There's never communication that is too much. We love our preceptors that stop by to share with us concerns, but we also love when you guys stop by to tell us, shout outs and great shifts together and wins that the orientee has had throughout their time. I think also just staying connected with your patients. We don't see this often, but I feel like sometimes there's just a notion of like, okay, my orientee has it, like she's got it, everything's good, she's got our patients, and we're good for the day, and I'm just going to sit back and let them take control. But really that doesn't happen until the final tier of their orientation, which we'll go over all of the tiers. It's so important that you guys stay a part of all of the cares and hands-on care, touch times, so that you know what's going on and you can report back to us if there's anything that's needed. Debriefing with your orientee on progresses and challenges. We'll get into a little bit of this in the next couple of slides on pre-gaming and debriefing and all of the different terms that we use, again, just for that communication with your orientee. And then, of course, just immediate escalation of any, safety concerns or any warning signs to the clinical mentor or your nurse leader. If it's night shift, we're not here, unit supervisors. They report off to us and we are always in communication with them. But again, we'll get into more of what those warning signs look like and things to escalate to us. Okay, so the NICU preceptor and the roles and the responsibilities. So I know a lot of you guys are either familiar with the fellowship binder or have seen the fellowship binder, when you've had orientees on the unit. So we've given them a binder to, keep track of all of the documents that they have to help, facilitate the progress that they have on orientation. We really just want to make sure that like you guys are seeing this binder. We're taking away some of the hard copy things, so there's like not as much for you guys to have to document, but just making sure that they're utilizing this binder appropriately and that they're bringing the binder onto the unit so that they're using the navigational tools. So like the TCM checklist, which I will show you guys in the next couple of slides, but this isn't something that's mandatory. We won't ask, like, hey, where's the TCM checklist, hard copy? How are you guys doing with it? This is really simply a navigational tool to help with you guys knowing like, okay, they've completed everything in tier one, they can now move on to tier two. Again, this will make more sense when I actually pull up the TCM checklist. But again, not mandatory for you guys to fill out, more a navigational tool for the orientee and for you guys as well. The assignment tracker. So this is actually one in my edits I forgot to remove, but we have actually removed the assignment tracker for the orientee from Teams. But we will be putting a hard copy into their binders so that they can just physically keep track of the assignments that they're seeing. And when you guys come into a check-in and tell us they're doing wonderful with acuity, but we're not seeing as many 3 babies, we can go into their assignment tracker and see like, okay, well, what kind of acuity have they seen? What kind of respiratory support have they actually been able to get their hands on in assignments? Or how many 3 babies, PO feeders, things like that. And then the biweekly QR code. So this is a QR code that you guys will scan. We'll go over the QR code in some further slides, but this is something that you guys will fill out together that just goes over how the orientee's feeling, how you're feeling about their progress on orientation, what tier we think that they're in, and also what goals we want to set with the orientee for the next couple of weeks. So biweekly check-ins. So you guys will check in with a member of either a mentor, educator, or one of our fellowship support team members, and your orientee every 2 weeks. So you should expect to see us every 2 weeks to check in again on those things that I was just talking about, goals that we're setting, progress within TSAM and the tiers, and overall if you're feeling like there's any concerns. I will say that in the biweekly check-in, we would like for you guys to bring up any concerns that you have prior to the biweekly check-in, just so that we can, bring up these concerns gracefully, and you're not alone in these conversations. We want you guys to know that, like, this is really what Jordan and I are here for, to help facilitate conversations where you're seeing some concerns, lack of progress, things like that. But this is a perfect time for us to sit down together and find solution and proper implementation of goals. We really don't want the tough conversations to all come out in the biweekly check-in. We'd like some of it to happen before and some of it to happen during, just so it doesn't feel kind of like a dog pile. We want it to feel graceful. We want it to feel supportive. Um, most of you guys know this, but we will be doing the biweekly check-ins, either, during you will always do it when you're scheduled to be here with your orientee. So it'll either be at the end of your night shift. So we shoot to like schedule it for like 6:30 a.m. or during day shift, and just depends on your schedule. We'll give you guys a call and, sorry. We'll give you guys a call during your shift and say, how's your day looking? What's a good time for us to meet? And we'll just schedule from there. We can always reschedule or with any conflict. So I have had people, if Darby knows that her and her orientee just had a check-in the week before, and then I'm reaching out to schedule another check-in the next week after, I have had preceptors contact me and say, hey, we just checked in last week. Is there any way, there's not really much that we have to talk about with, goals. We're still working on the same things. Can we push to another week? We're always happy to do this. And it's usually just an oversight on our end of, oops, didn't realize you guys just checked in. So always happy to reschedule if you guys, advocate for that. So the QR code, the biweekly QR code that I was talking about in the binder. This is again just a QR code that you will scan. Some of you guys may remember the hard copy form that we used to do. It's now a QR code that goes through Microsoft Forms. You do need to do it on the same device. So if Abby is my preceptor, she'll scan the code and answer the questions for herself of where she feels like I'm at in orientation. And then as the orientee on the same device, I will fill out how I'm feeling and my self-awareness of where I'm at in certain tiers. And then at the end, you guys will collaborate on any further observations you've had that week, or even if, and then of course your goals that you want to work on for the next 2 weeks. So a little open-ended space there. Some people will still get a message that there's a 90-minute timeout. People like will scan the code and see 90 minutes to take survey, and they panic and they're like, this takes 90 minutes. We definitely don't have time to do that. That's not what it means. It just means that the QR code will time out after 90 minutes. This timing message should be no longer on the QR code, but have had some people still see this message. I just wanted to make a message out to you guys. If you see it, please do not worry. It does not take 90 minutes. It's just a 90-minute timeout. Okay. TSAM understanding. I'm not going to go through all the things here. We're going to go over TSAM in the next couple slides. Feedback. So feedback is part of the roles and the responsibilities of our NICU preceptor, but we want to know how you guys are feeling about it. If you are not feeling comfortable giving this feedback, maybe there's been pushback, maybe you're not feeling comfortable with feedback yet, and you're just not at a place of having, those constructive and sometimes tough conversations. We love to hear that from you. please let us know, the circumstance, the situation, how you're feeling. All of those things are so important to us. But the big thing is that you do need to escalate it. So please, please, don't sit on something, even if it feels small. We want to know all of the things, even if it's something that we're not going to act on right away. It's just nice to have in our back pocket of like, okay, this has continued to be a concern of something that did seem small before, maybe was a green flag. Now we're escalating to a yellow, and maybe it eventually turns into a red flag. So again, we love to hear it all. We do like to emphasize feedback is best given in real time. Them hearing it from you, and also prior to a check-in, is just going to help you guys build rapport. They are going to trust you so much more with you bringing it up in real time. And I know that it can feel tough, it can feel awkward, but I will say that we have gotten feedback from orientees on how tough conversations have gone, and the appreciation that they feel that Maria shared this with me in real time, and I can't tell you how appreciative I am that it didn't come from a third party. That it came directly from her, and she cared enough to have that tough conversation with me, and not to talk about it, behind my back to others, all of those things. It really does mean the world to them. Um, and then also just a small piece, written feedback really is ideal and always appreciated. We love when you guys come to our office and fill us in on the things that are going on and that we need to know. But if you ever are just feeling like you want to get home, it's been a long shift, not having time in the day, we usually do need to ask for the feedback written down anyway to create a timeline and from your words. That's the most important thing, that it's not from our words, it's from you. So we do always ask for written feedback. I, have told nurses in the past to start a note on their phone. I, do share a lot of numbers with like the bedside nurses here, and I'm always happy to just receive a text in the morning from them of the notes that they had throughout their shift, or just sharing like an iPhone note with me that they can just continuously update. Whatever is easiest for you. I know that there's enough going on in your shift, and precepting is already taking up 12 hours of your shift in a role and responsibility on top of all that you have to do. So I want this written feedback to be, something that's not putting another thing on your plate, even if it's just brain dumping into a text to me or into an email. It's something that I can make sense of it and make it look pretty later. So again, always appreciated, and the written feedback is definitely necessary for us. And then the support, so just being a welcoming face, a resource to these new team members. And I know it seems simplistic, but being kind of inclusive and inclusive goes such a long way. That really just creates that supportive foundation that they need to feel not only successful here, but to feel welcomed. So just like taking a quick minute, I like to just like do this little exercise of like, I want you guys to just take a minute and to truly think back to your first day when you started on this unit, and all of the feelings and all of the emotions of coming onto this really large, busy, fast-paced unit. And I know that, like, looking at some of you guys, like, I remember when you were new, and that's such a special thing to be able to look at the screen and remember you guys going through fellowship. Um, so I know that you guys remember these feelings. I know that you remember, a time where somebody made you either feel included or the opposite. And that's so impactful. So whether your experience was positive, or you had a learned experience of, wow, that's really not how I want to be treated, like, or how I would want somebody to be treated coming onto the unit. I just want you guys to remember those things as you're the one that you are their mentor on the unit. You are going to be the one that they look up to, that they look to in times of need. And I know that you guys hold that responsibility, to a high expectation. But I just always like to give that, that first day flashback exercise and moment of just remembering what it felt like, and to take that with you. But just really doing the things that help them feel welcome and included. Sit with them at the nursing station. Don't put them in a cubby and then say, all right, I'm going to go sit in the nursing station. Include them in your conversations on the unit with your friends. Introduce them to your friends and to other team members. Not just the other nurses, but the doctors when they're trio rounding. We got feedback that somebody was just so tickled that, during rounds that they said, oh, by the way, this is my orientee, Dr. Troy. Like, just wanted to make sure that you got to meet them this shift. And that meant like it felt like so little to the preceptor after I talked to them, but to the orientee, it was huge. It made them feel so included and welcomed onto the unit. And then also just like inviting them to lunch. Just please make sure you're oriented. I know that sometimes it's just like, it's your time to you know, be away from the unit and decompress and have your lunch and have some quiet time. And I totally understand that. And if you need that for yourself, I think that just like telling them that's what you need. I think everyone's entitled to what they need during their shift. But then just make sure that they're not eating lunch alone and that they have a buddy near them. And then also just asking them questions. Again, these are all instances I've gotten feedback on. But we had an orientee once that was like, my, preceptor asked me what I was doing this weekend, and it was so awesome. And, that just made, it tickled me. But at the same time, like, I was like, oh my gosh, is no one asking you questions? Oh, is no one asking you anything about what's going on in your life? And I think that just asking those personal things also just helps them feel included, helps them feel like they're part of the team and that you care. Okay, so going into TSAM. So TSAM is the organization that we use to build on skills from simple to complex for orientation during their 16-week period that they are training with you guys. Really, the big things is that the orientee will be responsible for only the objectives that are within the assignment. So when they start off in tier one, they will have their hands in each assignment, both patient assignments if you have two babies, but they are only doing the skills that are within the tier that they are currently in. So it is not a divide and conquer. It's not this is, the stable baby is your baby for the day. The more complex baby is my baby. Let's divide and conquer the day. They have both babies, but they're only doing certain skills, and you're taking care of the other skills that are outside of whichever tier they're in. This is a nice little diagram of TSAM. We do give them a copy of this in their fellowship binders. So if you guys ever want to take a peek and have just like a little quick guide of each tier. So tier 1 through tier 5, the orientee's responsibilities, and then the preceptor's responsibilities, which we're going to get into like the nitty-gritty of what goes into each tier. But this is just a nice little quick resource of tier 1. Okay, so the orientee is responsible for assessments, vital signs, I&O, and hourly rounding. Those are the only things that they're taking care of. So the big things for the preceptor to cover are involving the orientee in all documentation, identifying resources on the unit, and narrating the cares and what goes on into hands-on care for each baby. And then really just building off of that. So again, just a nice little quick guide for you guys that you can reference in their fellowship binder. Before we get into TSAM, I did want to just go over a quick change with you guys. So a lot of you that are familiar and have been precepting, you will have noticed and are familiar with the TSAM hard copy that we put into their fellowship binders. We no longer need to fill out that hard copy form. We've actually moved this form onto HealthStream so that it looks like another one of the HealthStream checklists that you guys have already were responsible for completing. So we no longer need to do this. When you log on to your checklist, the evaluate checklist hyperlink, and you look up your your orientee, you will not only see the HealthStream checklist that you guys are familiar with, but you will also see the NICU TSAM RN orientation. So this now takes place of the hard copy, which you no longer need to fill out. Does anybody have any questions on this? Yeah, Darby.
Um, is so the TSAM checklist is now on HealthStream. Is that in
Exactly.
addition to that other checklist that we always used to do, that one right below it, the
This
RN?
one, this guy.
Oh, no, I wasn't talking about that one. I'm like the original health stream checklist that we were doing for with our orientees.
Oh, yes, yes,
Skills
yes.
checklist, Carly, that she's talking about.
Yes. So the skills checklist is still going to be that it will look like this. So this is your RN NICU skills checklist. That will still be a responsibility for you guys to fill out. But then you will also see a NICU TSAM RN orientation. And that is taking place of the hard copy that used to be in their binders. So
Got
now
it.
you'll just have two.
Thank you.
Yeah, of course. Any other questions on this change? Awesome. Okay. So, going into the tiers and, the responsibilities that go into each tier. So this is, the tiered checklist that will still hang out in their fellowship binder. So what we did here is we really took that health stream checklist that Darby was just talking about. We took all of those different skills and we put them into the tiers 1 through 5. This is not mandatory to fill out and to complete for your orientee. It's more of a navigational tool. We were getting a lot of really great questions of like, I don't know if I'm in tier 1 versus tier 2, if I'm completely out of tier 2 yet, and I can go into tier 3. So really this just helps again with all of the nitty-gritty details of the skills that fall into tier 1, tier 2, and so on. Um, just for your guys' awareness, we do have the wonderful thing about TSAM is that everybody goes through it at different stages, and that, there's no hard and fast rule of you need to be out of tier 1 by week 3. That being said, we do onboard very large fellowship groups, and I'm a bit type A. I just like to have like a goal in mind. This is not by any means, they need to be out of tier 1 by week 3, but we like to give just a guideline and a goal of this is when they should be somewhat coming out of tier 1. So I don't want us to, panic if we're at, week 3 and we're still, trying to accomplish some of these skills and haven't gotten to see maybe all of the thermoregulation settings that we have. That's okay. We've got some time. It helps us also implement and make some specific goals going into, the next couple of weeks. But with us just having such large fellowship groups and to be able to have some ideas of things that are going on, we do like to just have some guidelines here of when we would like to see them coming out of tier 1, going into tier 2. So for tier 1, when they're starting out on the unit, we're really looking at fundamentals, assessments, thermoregulation, and communication in a loose sense. Really, we're not looking at like full communication of things until we get into about tier 3, because we want them to build on their knowledge before they're communicating the skills. They're updating parents, they're escalating to providers, right? But we do like for them to start communication, and that we only have them for 16 weeks. So we want them to start connecting with parents and patients, learning 2 things about parents and or family members that they can't find in the chart. So just giving them kind of fun goals of building rapport with families, but not anything that's that they're having to give critical updates, background knowledge on patients. We just want them to be, engaged in asking appropriate questions throughout the shift. Those are the kinds of communication goals we have in tier 1. But again, these are the skills that we want them, taking responsibility for. Everything else, like medications, feeding, order sets, communication with providers and parents, those are all going to still fall on you. Okay. Another big skill for tier 1 that we like to emphasize on, safety checks right out the gate. I want, as soon as they start with us, that they are doing safety checks with you guys. They're being proactive about them. They're taking lead on them, but they're also communicating out loud that, okay, Darby, I'm lifting the ambu bag off of the arm, and I can see that the connection of the ambu bag to my actual oxygen source, this is what my FiO2 for rescue needs to be at. They need to be talking these things out loud, because if they're not saying them out loud to you and they're just lifting up the bag and eyeballing things, you don't know, you're not closing the loop on, do they actually know what the FiO2 needs to be at? What are they looking for when they're lifting the ambu bag off of the arm? Things to that nature. Any questions on what needs to be accomplished in tier 1? Okay. Tier 2, so a little bit more, detailed, a little bit more skills here. Ideally, we're in tier 2 between weeks 3 and 5. We're working on things like medications, INO, intake and output, handling of breast milk preparation, breast milk scanning, checking. More involvement with Epic documentations, order sets, seeing order sets go in and orders placed, and what needs to be followed through when those orders are, being placed by providers. Collection of labs, so things that involve specimens, observing cultures, uh, talking about lab findings and correlating those lab findings. And then again, trickling in some communications on, let's start giving report on at least one patient. Let's start practicing report on on your full assignment with your preceptor. Maybe you're not doing that, at total end of shift, but you're just starting to practice. You're just starting to get that exercise of what needs to go into report so that when they get into that communication phase, it doesn't feel like you're just kind of dumping on them. They've already started to practice some of these things. Any questions on tier 2? And also just for reference, they have not lost the skills in tier 1. They're still documenting, taking care of vital signs, and doing their safety checks, all of those things. And they're now adding on to their plate of responsibilities, the things from tier 2. Okay. Please just stop me if you guys have questions. So tier 3, this is where we're getting into a little bit more of the complex understanding, high level, high risk care. And we're also getting into more of the communication. This is where we want them to start holding the phone. They're holding the phone throughout the shifts. They're communicating with providers. What is Epic chat worthy versus a phone call? What does escalating an SBAR look like? What are you saying to your providers if you need to escalate on a status change or a critical lab value? And really just getting into the details of overall communication. Even like, a tougher parent update. Like at tier 3, I wouldn't say like starting with that, but I think that just starting to talk to them about what you are going to say to a parent that maybe we're delaying discharge. How is that going to look for you? And then in tier 4, starting to like actually let them hold the phone for an update that, maybe you had to go up on respiratory support or increase on FiO2, baby didn't PO feed well that night, whatever the situation is. I'd like for them to have some tougher conversations with the guidance of you there so that when they come off orientation, they're not having the first tough conversation on their own. Of course, I look to you guys to be the experts of maybe this isn't the family, maybe like I'm not trying to throw them into this situation. It may be a family that needs a little bit extra TLC kind of situation. But overall, just wanting you guys to include them in what those tough conversations look like and how to navigate through them. This is also where care planning really comes in, that they're starting to correlate, certain labs with changes that we made to respiratory support, or maybe needing to give a blood transfusion, titrating certain feeding orders, what that looks like. And also just seeing the different procedures. Really, ideally at this point, we're hoping that time management feels pretty good. And this is a place where you can take a hands-on care, let them go see a PIC placement, let them go see an admission, let them go watch a discharge. Just allowing them to, again, get their hands outside of their assignment a little bit, because it's hard to see all of these things when it's just within your assignment. So always advocate, if it's an appropriate situation, have them go see all the things. So then tier 4, this is where we're getting into those experiences again of admissions, discharges, transfers, that they are managing assignments. Like maybe we're getting back into that place of getting more three babies, double bubbles, room air, high flows, because we're getting towards the end of orientation. We want them getting back to the place where they're not just getting exposure to three babies and double bubbles, but they're managing the assignment. They are taking on the workload, working with, delegation and prioritization is more tier 5, but we want them to start practicing it at this point and just dipping their toes in the waters of prioritization, delegation, and things like that. And then tier 5, again, this is overall workload management. They're handling appropriate assignments. We're not looking for them to be handling SBU, intubated patients, babies that are really sick. We're not looking for them to thrive and be independent in those assignments. But the double bubbles, the three babies, the high flows, room airs, babies like that, we are expecting, for them to be managing the assignment, but also identifying when they need help, when they need to delegate, when they need to reach out for questions, concerns, things like that. And then there's also just little things in here about, making sure that they're doing health stream completions, that they know how to utilize Smart Square, that they're knowing who to go to for help, that they're doing their hourly roundings, they're doing their breast milk checks with other people. I think this is also a really good time to start saying, you know what, why don't you go check your breast milk with somebody else, so that it's not so much a culture shock when they come off orientation and you're the safety net of their preceptors not there to do all of their double checks and to be the one that's checking off their breast milk and things like that. So going to other nurses, maybe even going to RT to help with some respiratory support and care. So that's really, tier 5, overall, just handling the assignment and handling workload management. Does anybody have questions on the tiers, how we progress through them, or the skills that go into them? No? Okay, wonderful. And again, that checklist, wonderful to have. We don't ask for it back at the end of orientation, but we do just want you to use it to help navigate you guys through the tiers with your orientee. So why TSAM? We kind of already talked about this. Really, the biggest thing is we don't want you guys to be doing the divide and conquer. This is your baby. This is my baby. We want them to have hands in each assignment that you guys have, and really so that there's not that, again, culture shock of coming off orientation and being like, oh my gosh, all of these babies are now mine. I usually just took one or two of them. We want them to have access to slowly and gradually putting on their plate what they can manage. So some changes to orientation. So we did this with the August group and cohort, but just since this will still be new to some of you guys, since you either were precepting for us prior to beginning of 2025, prior to us making these changes. But we really wanted to make our class sizes not only smaller but more flexible for class schedules and overall sizes. We want to have more one-on-one time. We felt like having these large fellowship groups, the best way that we could really make intentional time with everybody is really to break them up into two cohorts. So cohort A and cohort B for our winter fellowship group. That allows us really to, again, have the smaller class sizes and also smaller skill stations for them. And that we also were having these week-long classes where it was hard for them to manage that in their schedule. So overall, we, did this with the August group. We got wonderful feedback. And we're going to be implementing this also in 2026, but in a different way, that we will have smaller cohorts that we're onboarding, but we are just going to be onboarding more frequently. Pretty much we'll be starting a fellowship group every other month, but those will be cohorts of not 30 new team members, but 15. So we're hoping to implement these changes that we made, but just doing it now in the smaller cohorts for 2026, which we're excited about. And then also a change that we made, so a universal 16 weeks on orientation for both new graduate and also new to specialty. The new to specialty nurses, so they were RNs before, but just in different specialties, different units. We used to give them 12 weeks, but we're now giving everybody 16 weeks on orientation, just because the NICU is so unique, it's so niche that it's hard for, you know, even our fellows to come on and only be given 12 weeks. We get a lot of times that they wish they had had 4 more weeks just to become acclimated to the NICU. So we were very excited about that change, which is wonderful. This is though where we will really look to you guys for help in that if it is a new to specialty nurse and maybe they're ready to come off at 12 weeks, they're thriving, they're independent, they're doing well at around that 12-week mark. If you guys come off or you guys come to us and say, you know, I really feel like they're ready. They are managing the assignment. They're asking all of the right questions. We're always welcome and willing to look at the circumstance and say like, okay, let's pull them off orientation. But it needs to be a group effort of not only the orientee being okay with it, but also you guys as the preceptor having your guys's observations of them being ready. So just want to go over some things that we're teaching in fellowship in case like, you know, your orientee comes to you and say, well, Carly and Jordan taught me that I should put everything on my bedside cart in organized order. And you're like, what are they telling you? These are just some things that we teach in fellowship and reasons why. So healthy habits, really the things that we are teaching in small groups in our fellowships is to help with them again, putting on their plate what they can manage, working smarter, not harder, being efficient in their time. So the things that we're teaching them, arriving to work on time and appropriately. Please let us know if you like. You guys are the first ones to know. Saj has so many time cards that she's going through. Every payroll. It's rare that she like will identify like, oh, like this person didn't clock in and out on time. And it's so important that they aren't running into shift late, that this is a new unit. They should be arriving early. They shouldn't be arriving late and disheveled and, like stressed that they're not clocking in on time. We want them to be arriving. They should be arriving before 7, clocking in before 7 a.m. or p.m. So usually you guys are the first ones that notice this. So please let us know if you're starting to notice that like, my orientee is not rolling in until we're scrubbing at the sink or like in the middle of report. Please just let us know these things. Safety checks. So safety checks are a part of their responsibility. Like I said, we teach this to them their first small group day, all of the ins and outs, and give them also a safety check resource guide. Like I said earlier, though, please just have them talk through what they're doing so that you're not just like watching them go through the motions. They might not know what they're doing and they're just mimicking the actions that we're showing them. We want them to understand the reasons why so that it just has it has some substance for them of why we do the things that we do with our rescue equipment. Ensuring that we're instilling organized habits and expectations. So clean and tidy rooms and babies. I know that, they're in a place where they're checking the boxes, they're doing the things, and sometimes cleanliness or a tidy room is the last thing that they're thinking about. But I want you guys to hold the expectation that, we don't want a parent to come in and see a room that's totally disheveled, and no less their baby. Just talking to them about what that feels like for a parent to come in and see that their baby's not swaddled or at the bottom of the bed or a mess everywhere. It's just not a good look and an expectation that we need to set. Restocking your cart for the next shift, set your friends up for success. You guys know what it feels like to come in and start the shift with an empty cart. It's no fun, no good. So please just make sure that you're instilling those habits to them of at the end of your shift or start of your shift or both. We need to be checking our cart, making sure that it's appropriately filled and that our next nurse is set up for success. And then baby is always nested, developmentally appropriate and tidy. We talked about that. going in early to be on time for hands-on care. So really the goal should always be that the feed is started at the care time. For those babies that are getting 2.5 hour feeds, their bellies are only getting that 30-minute break between their feeds, and that 30-minute break is essential. So really we need to make sure that the feed is not being started 30 minutes after the care time. It really needs to be started on the care time. And just making sure that that's set as expectation. Making sure that they have an organized hands-on care. This is going to take some time, but pre-gaming with them and talking with them about what that looks like, having them utilize this bedside cart organizational tip that we share. I tell them that they need to get all of their materials in their prepping of going in early for hands-on care. They need to be grabbing all of the materials that they need prior to going into their hands-on care. That in and out of the room for, oh, I forgot the stat strip. Oh, I forgot, oral care kits. Oh, I forgot this. That's going to slowly tick on time to their time management. So making sure that they have all the materials, but then I also want them laying out these materials in the order in which they're going to carry them out. This also just helps with an organized and efficient flow, so that when they do have a moment where maybe a parent comes in or maybe a doctor comes in and starts telling them orders, they can look down at their bedside cart, and even though a little wrench was thrown into their hands-on care and their flow, they can look down and say, oh, I was at my oral care kit. I haven't opened this yet. This is the next thing that I'm going to do, and where I left off in my hands-on. We have seen time and time again that people will start to slowly stop doing this on orientation, stop organizing their bedside cart like this. And, just recently I had a conversation with somebody where their time management was not where it was needing to be, and they weren't doing the organizational tips anymore. And it really came down to flow of care and forgetting where they were at, or needing to go in and out of the room to grab materials. We really need to make sure that they put that time up front to not only prepping for the hands-on care, but also just laying themselves out and getting themselves organized so that their flow feels good. Time management concerns, kind of going off of that topic, but when you guys come to us, this is something that even off of orientation, some of our orientees are working through and working on. But if you guys come to us and Maria says, my orientee is really struggling with time management, I don't know what to do, the first thing I'm going to ask Maria is, what's going on in the room? What do you think is taking the most time? So the biggest thing that we want you guys to come with is just the, well, the baby, like the touch time in general is taking like 20 minutes. Flow feels unorganized. The prep time, like they're in and out of the room going to grab things. So really your observations here is what's going to help us implement the specific goals that we need to helping that orientee get their timing down and making sure that they are working smarter and efficiently with their time. Any questions on these healthy habits, or maybe things that have come up with your orientees that you've seen them implement this? Suggestions of the tips and tricks that we're talking about? No? Okay, wonderful. Central line changes. So I am going to go through the central line change. A lot of you guys have heard or been through our central line change skill station and skill practice that we've implemented. We've done a lot of things to change this skill training and practice, even down to renaming it from competency to assessment. Really just trying to make it about education, experience, and practice. We don't want this to feel like a test for them, but we do want to implement a safeguard of checking in on their central line skills, because it's very important to our babies and our CLABSI numbers, of making sure that not only do our team members know how to hang lines, but how to protect them as well. So if you are on night shift, you will be doing central line changes with your orientee. The goal is for you to hang a line every night. We want you to obviously, let them observe you changing the first line change. But then from there, we really want you guys to allow them to get the hands on the skill. The goal is for them to have 5 central lines scored on this central line scoring sheet. So these are scoring sheets that we give them for them to fill out with them and their preceptor. So things that you guys will be filling out with them. So they also know how they're being scored and what the expectations are of a safe and effective central line change. Um, for your guys' awareness, it will actually say on the sheet, this is just a snapshot of it, but this first part is the orientees assessment. It's so important for us to know how they are feeling in the certain skills that they're doing. And then this part here, this darker purple, is where you will score them on these different expectations of the central line. If you ever score them any less than a 4, so 4 is complete independence and 1 is not meeting expectation at all. If you score them any less than a 4, we have this nice little comment section over here. Please just take the time to write a comment on why they didn't get a score of 4. And also just emphasizing to them that the first couple line changes, they're going to need coaching. It's very appropriate that they're going to need your guidance. They're going to need coaching through some of the expectations. So just letting them know it's nothing punitive. It's just allowing us to track the practice that they're getting. And if there's a particular skill or expectation that they're struggling with, like connection of line to baby, then we're aware of what where their challenges or opportunities lie. The line that they will be hanging in their skill assessment will be a PIC line, TPN and lipids with a med line, and they will need to change the blue clave. So it'll be a Monday or Thursday PM. So just so that you're talking to them about these things, it's often that sometimes people don't catch a line change on a Monday or a Thursday night shift. But just talking through with them what it looks like to change that blue clave on the end and how it looks at bedside. But just so you guys also know, we're doing a skill practice day with them where we're showing them how this skill also works in a skill station. So just wanted to go over the expectations and what they look like and how to coach your orientees through skills through central line changes. So the first expectation, prep for sterile line change. So really just making sure that they're grabbing the correct number of pumps, that they're grabbing the correct fluid and checking the fluid appropriately. Common things that we see is grabbing the correct lipid tubing. So making sure that they know the expectations of what lipid tubing that we're using. You can always reference our line diagram that's on Teams of when we use the mini bore, small extension set, and then when we use the larger filter and straight tubing. So just going over with them those criteria and expectations. Also cleaning their environment. So we do ask them in their skills day how long it takes for dwell time of Oxivir and bleach. So just making sure that they're cleaning off their areas before setting up their line. Oxivir takes 1 minute to dry, bleach takes 3 minutes. So just making sure that they are aware of the dwell times of the cleaning products we're using. The biggest thing that like with sterility, if they come to you, we've had a lot of preceptors, say like they're so worried about breaking sterility. That's their biggest concern. Just telling them that the biggest thing to us is they just need to declare when they've broken sterility. That's our biggest thing. The biggest red flag and concern we see is when someone's breaking sterility multiple times and they're not saying out loud, oh, my flush rolled off of my sterile field, or I'd have to go get a new blue clave, it bounced off, or my sterile glove touched the outside of the 1-inch border. So just tell Carly and Jordan when you're doing the skill, oh, I broke sterility. And then we just ask them, okay, what would you do? What would you do to correct that break in sterility? Next expectation is connection of materials. So connecting all of the materials that they grabbed, really just using their resource on Teams. If you're continuously finding that they're having issues with connection of where things need to go, suggest them making their own line diagram. This is wonderful, but it doesn't work for everybody's brain. Maybe they need more colors. Maybe they need something that's just actually drawn by them. Suggest to them to have actually make their own line diagram. They do need to have some kind of line resource while they are learning to hang central lines. They shouldn't be doing this, like, I don't want to say blindly, but it feels that way. They should have some kind of resource taped up and in the room. Um, Another big thing that we see with common things that are missed with collection of materials is also clean versus sterile flushes. I know some people are still grabbing the sterile flushes. That is not a practice that we should be doing. We should only be hanging clean flushes onto our central lines. The sterile flushes are large amount of fluid, unnecessary, and we're connecting the clean flush to a blue clave in a closed system. So we need to be using those 5 ml clean flushes. But biggest thing is that they're not opening the clean flush and putting it on the middle of their sterile field. They're opening the clean flush, popping the air out, and putting the clean flush on their 1-inch border with their lipid syringe as well. Where does the 2-way and the 3-way go? So just making sure that, like you guys learned from Competency Day, just making sure that the 2-way is going from bag to baby. The 2-way goes first here, and then that connects to the 3-way, which connects to baby. This allows for that Medline math to make sense. So just making sure that they're connecting those in the proper order. Knowing how to attach and prime the blue clave on a Monday and Thursday night. It's very common that we'll see people in the skill, they will have the blue clave not attached at the end or primed through, but they just don't know the process of the blue clave actually has to be on the end of the line and has to be primed through before connecting to baby. Maintain sterility if breaks in the sterility. We already talked about that. Just if they break sterility, make sure that they're calling it out and what they would do to correct that break in sterility. And then also just making sure that as they're connecting things, everything should be clamped because we really want them to get into the habit that the only thing that should be unclamped is what they are priming through. So for instance, that, if we're priming through the TPN, we don't want our med line to be unclamped here because it's going to cause that TPN to negatively backflow up to the med line. So we want to make sure that they're in that healthy habit that the only thing that should be unclamped is whatever you're priming through at that time. Does anybody have questions on either of these objectives with central lines? No? Okay, wonderful.
Quick question, Carly.
Yeah.
I've heard some when I filled in recently that the expectation is to use sterile 2x2s to grab lipid syringes and open the bag for TPN. Is that how you want us to teach it?
No, not necessarily that. It is not the expectation. And wonderful question. So that was just a tip and trick that I shared. We actually haven't been sharing that as much because I feel like it confuses people. I really only implemented that with actually my orientees when they were really struggling with the clean hand versus dirty hand of this is now my dirty hand, this is now my clean hand. I just utilized, let's drop some 2x2s and 4x4s so that when you're going to grab things, then you're maintaining sterility of both hands. It is not an expectation. If you are finding that your orientee is really struggling with that one hand is clean, one hand is dirty, then you can start implementing that 4x4 and 2-way situation, 2x2 situation. But by no means is it the expectation. They can use the clean hand versus dirty hand connection technique. Does that make sense, Olivia?
Yes, thank you.
Yeah, of course. Great question. So connection of line to fluid. So this is kind of going over a little bit of what we were just covering with Olivia's question, but one hand does need to be maintained as your clean hand that's handling the central line, while one hand is labeled as your dirty hand that is handling the bags and the syringes. This is also why we do set the expectation that really they should have everything connected prior to starting priming. So they need to connect their TPN, they need to connect their lipids, then they need to connect their flush so that everything is closed so that when you're going through of flicking the line and manipulating the line, everything is closed. You're not risking any kind of contamination of the line, of any part of the line being open. So we do with the fluid connection portion, we do really, while they are learning and they are new to this skill, all of the fluid needs to be connected prior to the priming being started. So really the best way to teach that, if you think of the proper order of things so that you have to do the least amount of connecting and disconnecting specifically with the flush, it's best to connect the TPN first. So spike your TPN bag, connect your lipids, connect your flush to your extra port, and then begin your priming. So you'll flush through that extra port with your flush, remove your flush and connect it to your med line, prime your med line, then go to prime your lipids and then your TPN last. So that you're just going into the order. You're not, a lot of people will go, okay, I'm going to connect my flush to my med line first and then flush it and then go to my extra port. The flush has to stay on the med line. So really you're just limiting the number of disconnections and connections that you're doing, and again, lowering your risk of contamination of the line. I know that that's a lot to like read off. It's like more of a visual thing, but does anybody have questions on that, or in like any things that they've seen that are different, or any clarifications I can give on that process? Okay. Priming fluid, pretty simple, really just making sure that no bubbles are left behind and minimal fluid is lost. We really just want to make sure, and really this is going to be big with making sure that everything is clamped prior to them starting the priming process. I can't tell you the amount of people that have forgotten to clamp right below the spike of the clear link. Fluid starts to rush in, bubbles everywhere, and really getting all of those bubbles out leads to like a very excessive amount of fluid loss, unfortunately, from the bags. Please make sure that your orientee is inverting and flicking the Luralock ports. We've recently gotten a lot of feedback that people are like telling their orientees, oh, well, if you like let the fluid go through those Luralocks fast enough, you don't actually have to flick. That is not true. Per the manufacturer, bubbles will get stuck in those Luralocks and they will hide in there, and it will be an issue for you and your line. And the pump will read off all kind of, air and line issues for you. So please make sure, again, you're inverting those Luralock ports and you're giving them a nice good flick to expel any of those hidden bubbles. Also making sure that you're turning the ClearLink filter upside down. Some people call it the tampon filter. Making sure that you're turning that upside down as fluid is filling into it, so that that's the proper way, again, per the manufacturer, that bubbles will get caught into that filter and filter out your line appropriately. Small lipid filter, just fun fact, some people don't know, there is an arrow on that small lipid filter, just making sure that you're pointing that arrow up as fluid is priming through that small lipid filter. And that everything is primed through. This is a big, big thing. We really don't have many people have to do a central line skills checkoff that they have to redo. This is one thing they will have to redo for, because that's a huge safety risk of if they don't identify like, oh, I didn't flush through my extra port. That's however many cc's of air that baby could have directly go into their central line. Very scary. So I think that biggest emphasis in like the safety of it all, and with central lines, just making sure that you're telling them you need to double, triple check that you have flushed through everything, and making sure that there is no air in your line. Any questions there?
I have one quick question.
Yeah.
I still do the 4x4 method with those. Do you want me to like practice like the one and dirty and then teach them that way? Or is it okay to teach them the 4x4?
I think whatever works best for your orientee. I think if the 4x4 works for you, teach them that way. Let them observe how you do it, but then you can also tell them there's also a process of where, and maybe it's a situation where they just observe somebody else hang one of their lines that night that does one clean hand, one dirty hand, and whatever works best for them, really. It's just more of like a teaching preference. As long as their hands, they don't intermingle hands, and they know how to use the 4x4 technique, I don't care what they do, whatever works best for them.
Sounds good.
Thanks, Abby. Great question. All right. So connection of line to fluid. So this is a big one where a lot of people have a lot of anxiety because this is the point where they have an exposed pick, right? So totally understand and appropriate nerves are there, but really the setting themselves up for success is the biggest thing that I just suggest as a preceptor, that you instill the healthy habits of putting the work forward and making sure that they're, again, set up for success for a clean, sterile line change. So even things down to what side of the bed the lines are on. So I want you guys to get them into the habit that maybe even the portholes, these portholes up here have your new line in one porthole, old line in another. Have your old line on one side of the baby, new line on the other. We've had a lot of instances in feedback where in the heat of the moment and of disconnecting of everything, we've had people disconnect the wrong line that they just hung for their baby, which is, scary and very unfortunate. So we don't want anybody to run into that. And we want there to be like major differentials of this is my old line, this is my new line. I even would go as far when I was teaching that I left my Kuros caps till the absolute end. I left my green Kuros caps on my old line, and I had no Kuros caps on my new line, so that even there was a color differential to me that, okay, like I know that this is my new line because it doesn't have Kuros caps on it yet. Okay, so set up for success. Make sure that there's enough room for your 4x4. Also, if like you need to swaddle a leg, make sure that that leg isn't going to be a problem for you when you're changing out your line, making sure baby is comfortable, and also just making sure that you have enough space. You're not cramped for area when you're changing out your line. You will need to have a 4x4 with 3 alcohols on it. You can see here that we're using this sterile field in that this should be your dirty side where your old line is hanging out. And then this is your clean side where it's got your new line out of the 2x2 with your alcohols ready to go. Some people like to keep the new line in a 2x2 kind of like crumbled up, but like safely near this sterile field. Totally fine if that's what you want to do. But again, set them up for success to kind of decrinkle that 2x2 so that when they go to get the new central line out, they're not fighting with the 2x2 trying to get the central line out. But either way that you want to teach, I'm fine with either as long as they are able to maintain sterility. Also just making sure you have a safe place for the pick to fall. This pick has like a nice long, not, I wouldn't say long, but it's got like a decent neck on it where you're not having to fight for space. If you are working with maybe an arm pick, a pick in the cephalic, or you're working with a shorter leg pick, making sure that like if you need a total different 4x4 or even a 2x2 underneath your line, the last thing that I want to happen to you is that you don't have a safe place for this line to land if, God forbid, they drop this line during the central line change because the baby kicks. I don't want this line, this exposed line, falling onto an area where we clean diapers, we have wipes, we have diaper cream. Not a good situation. So making sure you have a safe place for your pick to land. Double check that all is ready. Make them do a pause. Again, this is the most nerve-wracking part of the central line, and just have them take a minute to look around the room, look at their setup, make sure that they feel good about that, they've got all their materials ready. In that prep, I do suggest having their sterile gloves open and ready to go. So it's one less thing they have to fight with before they go to clamp their baby and get started. Cleaning the correct area of the pick. So once they have their central gloves ready to go, they'll clamp their pick line and they'll put on their sterile gloves. The biggest thing that we do give feedback on is the appropriate area to clean the pick. So a lot of times, let's say this blue clave is coming off. This blue clave is being changed tonight. We have a lot of times people will they have to clean that outside connection first, right? For 15 seconds and let it dry for 15 seconds. A lot of times we will have people clean the connection between the line and the very start of the blue clave, but that's not where we're disconnecting the line for a blue clave change night. They actually need to be cleaning between the pick and the blue clave. So just talking with them of where's the appropriate place that you are going to clean your pick tonight. Okay. So overall steps, they'll grab one of the alcohols here. They'll grab the pick. and they'll grab their second alcohol to clean the connection of the outside between the pick and the blue clave. They'll clean that for 15 seconds, then let it dry for 15. Another thing that we give feedback on, and it seems kind of silly, but I understand the reason that they make it, but they will leave that alcohol swab on that area and say, okay, I'm letting it dry for 15. You actually have to let it breathe. So have them remove that alcohol pad away from the area to give it that accurate 15-second dwell time. Then once you have that 15-second dwell, they remove the pick. So they remove that blue clave from their pick, take the last alcohol, clean the exposed pick for 15, let it dry for 15, and then they will connect their new pick to the line. Okay. Then they'll start their fluids in their new pump, make sure that the fluids are going, and then they always need to make sure that they unclamp bag to baby. So making sure their bag is running, their line is unclamped, and then baby last. Because of that, we want that positive pressure of the line is open, fluid is coming down, line is unclamped, and we're going into an unclamped baby. Anything else kind of creates that negative pressure and can cause the pick to backflow, and just don't want to risk any kind of like compromising of the line. So just making sure that everything's unclamped, fluid is going through, then unclamp baby. Any questions on the central line? Okay, I know that's a lot of details. Oh, and then how could I forget? Hourly rounding and CLABSIs. So just making sure they know how to manage their central line. So knowing that they should always be managing their central lines with wearing gloves. They should never be handling a line with bare hands. We change our blue clays Mondays and Thursday nights. Heroes caps go on all of our ports. No more than one extra port for emergencies, and then we can build off of that if any drips or emergency ports are needed. I think that they are in the mindset of like, we work in a unit with such sick babies, we should have as many ports as we can just in case. But just always going back to that CLABSI bundle of more ports means extra risk. Fluid bag and syringes need to be labeled, so bat labels on the bags and the lines themselves. Assessing necessity of the central line. So I know that that's more provider driven, but it should be on the nurse to just, be checking in on, are we going up on feeds? Are we titrating fluids appropriately? Because least amount of days that central line is in, again, decreases infection. And then always assessing volumes of bags and syringes so they don't run dry on your shift. We never want that, but that should just be part of their hourly roundings of things. So just making sure they're aware of the CLABSI bundles of it all. Getting into other assessments. So we do the central line skills station, but then we also do a med assessment. So what it looks like for giving meds with your orientee. So really making sure you guys are doing your due diligence with them of utilizing all resources when giving medications with your orientee. They should be practicing their 5 rights with you, knowing the medications that they're giving, why we're giving it, and doing the research into like neofax if they have any questions on things. I want them to get into the habit of not just utilizing you. That's going to be, like when they're first on the unit, but then we want them to start concentrating on utilizing neofax for correct dosing, why we're giving certain meds, and just making sure that they're doing their due diligence of educating themselves. IV medication should never be given alone. They just don't utilize the med line enough for them to be giving IV medications by themselves. So you should always be at bedside when they're giving anything through an IV. Always make sure that you're having them perform med math prior to giving the medication. If they are struggling with med math and you're starting to see like it's just not clicking, it's not coming together, please reference there is a med math admin sheet on Teams that they can utilize and do some med math practice. They should know what they're giving and why they're giving it. It's completely unacceptable if you're giving caffeine and they're like, oh, well, the baby's sleepy. Like, nope, that's not why we're giving it. They need to know the ins and outs of why their babies are getting their medications, and we need to instill that upfront and right away. Great catches. I think that really just like emphasizing to them that we are the last line of defense. that we have seen great catches that have gone through a provider ordering a med, pharmacy fulfilling it, and it going through a pharmacist, going through a pharmacy tech, and then our bedside nurses, again, last line of defense, that have caught really scary things coming to our babies. So just making sure that they are doing again, their due diligence of checking all things on Neofax and doing also their med math. So to go over the med assessment and what that looks like in case any of them ask. So it is a 30 question test with the passing score of 80%. Some of you guys I know have taken this med assessment. We have done some changes again to make it more friendly. They now can take the med assessment at home. They still, like previous, this isn't a change, but they have unlimited access to all of the resources that we offer, Neofax, calculator, notes that they take. So really want them to be successful in completing this med assessment and having just an appropriate knowledge and expectations of med admin on our unit. But please show them how to use Neofax and how to navigate it. It's one of the things that they can use. Show them the resources on Teams, like the transpyloric med resource, compatibility chart that's in the med room, and also just where to find certain medications, D10 bags, normal saline bags, amp and gent. These are all questions that we have on the med test that we want them to be aware of. So just, educate them, be with them, and support them through med admin on our unit. Just one last little quick note about feedback. I know we talked about it a little bit up at the front, but I'll always just kind of like to close with, please, please, please bring us all of the feedback that you have. Like I said before, there is nothing too small. There is nothing too little. We want to hear all of the things. But I think also in real time, don't sit on anything, come to us and let us know. And if you feel comfortable, share with your orientee the things that you're feeling, the things that you're seeing. They really do appreciate it. But you're not in it alone. You're not alone in the giving feedback scenarios of things. Again, this is me and Jordan's job to be here to help facilitate these conversations, to be supportive for not only the orientee, but for you. You should feel supported during these combos as well. But feedback in real time, just some small suggestions here. Find the right time. I think that if parents are in the room, they're in the middle of a care, high stress environment, might not be the time because they're not going to remember anything. They're only going to, remember the feelings that they're having or the chaos of it all. So it might be like a debrief situation of maybe I should, sit with this and we talk about this after the care. My biggest suggestion, give a compliment where a compliment is due, and then add your constructive feedback. I think it's nice to just give them some wins that they've had in the day, because, being on orientation, it's a lot. You feel under a microscope. You're not the only one that's giving them feedback. They're hearing it from other preceptors. They're hearing it from us. We're giving them feedback too. So sometimes it does start to feel like a dog pile. So if you can throw a little something in there about how wonderful their rapport is with parents or their thoughtfulness with the baby. It's just a wonderful thing to add into your conversation to help it feel supportive. We like to say drop the butt. A lot of the times, I don't want it to feel like you're giving a compliment, but your time management's really not great. Try and drop that butt of giving the compliment, but then changing butt with and. You're doing really, really well with your rapport with families. I can tell how much you care. What I would really like to work on moving into these next couple weeks is time management. I feel like we could really capitalize on getting our time from 30 minutes to 25. Just when you add that but to things, it's all they hear. They're like, oh, okay, never mind. Yeah, I didn't even hear the compliment before. So I think still give the compliment, just add on to it. Just give it that extra, make it seem like that feedback, because it is coming from a good place. You want the best for them. You want them to be better. You care about their success on the unit. So I think coming from it at an angle of you're doing so well, what I'd also like to work on and put onto your bucket of wins that you've had this week is seeing you capitalize on handling communication with providers. So I think that it's all in the way that you bring things up, and Jordan and I are here to even help with you scripting how that conversation goes if you need the help with it. Any questions on feedback or even like situations that you've had that you'd like to share that maybe could have gone better or that you learned from, or things that, we can help with? Wonderful. Well, we're here for all of it. Please come to us. We want to hear all the things. Okay, so what to escalate? So when the feedback becomes a lot and you're like, I don't know when to go to them, always come to us. Again, there's nothing too little, but just some major things to hit. So major red flags or things that you need to escalate to us immediately. Not following unit policies, so attendance issues. So like I said, if you're seeing them roll in late, they're not attending huddle, please let us know. They know the expectation that they should be clocking in before 7A and 7P. Longer than normal break times, if they disappear and they're off the unit for 45 minutes to an hour and they're gone for lunch, you've got to let us know that as well. Not adhering to dress code. We've seen some interesting things. Fig is selling some interesting scrub tops recently, and one of them's a tube top. I don't know who signed off on that, but we have seen it before. So please just, let us know if you're seeing anything like that. Sleeping during night shifts. We know night shift is tough. This is feedback that we've gotten, but it's also a safety concern. So if you're noticing that they're nodding off, tell them to go for a walk. Tell them to go get a coffee, go get a soda, go get a tea, do what they need to do. But at the same time, we do just need to be escalating. You need to be escalating this to us so that we can have those conversations and have it on our radar. Productive and proactive. Are they looking for things to do on the unit? It's unacceptable to be excessively scrolling on their phones. There's so much to learn. There's so many resources on Teams. There's so many procedures that are going on our unit. That excessive scrolling on the phone should not be happening while they're on their shifts. Working on assignments during their shifts, they do get paid for this time. We pay them outside of their hours that they're working their shifts that week. So please just let us know if they're like excessively working on assignments. Again, we don't want them doing that on their shifts. And advocating for experiences. I think that, emphasizing to them, and you can just steal this as evidence from me or advice from me. The most successful people that we have seen come off orientation and on orientation are those that advocate for experiences. They don't sit in their own assignment. They're asking what they can see, what they can do, admissions, discharges, what can they be a part of? And I think that just sharing that tip with them. Lacking ability to retain basic info. So if there's like, some exceptions to this. A lot of times it may just be that, they're new, it's a lot of information, but if it becomes excessive and you're having to do multiple reminders on very basic concepts, or, after feedback is being given or teaching strategy, you've even changed your teaching strategy up to, pivot to what they need, and you're still seeing these concerns, please come to us. Because if they're unable to demonstrate comprehension of skills, we're just wanting to get involved and help pivot, maybe micromanage what goals we're making, maybe even micromanage assignments for you guys. But we want to make sure that this is short-lived and that maybe it's just feeling a little bit overwhelmed at first, which we can see. Lacks awareness of limitations. So if they aren't seeking guidance from you on getting a baby out to do skin to skin and they've never done it before, or taking apart a dressing of a PIV and not asking for your help. These are just some examples, but if they're not coming to you and escalating certain things, these are definitely safety concerns we want to address. Or if they're needing to be intensely prompted to even ask questions on certain things, proving to not ask questions at all. Those are things we're going to want to talk about with them. Having blind confidence in doing things that are unsafe and just overall unaware of resources. Loving the NICU. You know, this isn't something that's malicious. This isn't something that, you know, the NICU is not for everybody. It's a very unique place. And a lot of times we're onboarding new graduate nurses who this is their first jump into the nursing world. Um, their NICU or their nursing school experience may have been my NICU experience in college in nursing school was so different than the unit that we are on today. So, you know, just telling us if you feeling like they're not loving it, again, we want to have that conversation with them and that we support them in wanting them to be in a place that fills their cup. And we want to keep them within a Nova, especially if they're wonderful. We want to find a unit that is a good fit for them. So I think that just encouraging them, they trust you guys. They spend a majority of time with you guys. If they're telling you these things, please encourage them to come talk to us, that we are open to helping facilitate, find a place that's for them. We aren't, you know, just going to blacklist them and say, okay, see you later. We want to help find a place for them. Also just observing how they act with the babies. If they have odd, apathetic comments towards not only the patients, but maybe the families right out the gate, this needs to be a conversation we have early on, and that, again, setting appropriate expectations, but also kind of getting to the knowledge of, is this the right place for them? Because we want our patients and our families to be a part of only supportive care. Okay, just getting into the documentation, we kind of already talked about this, but HealthStream, very long checklist. So you have the checklist and now the TSAM checklist that will be a part of your guys' responsibilities of checking off. You guys should just go in each, you know, I would say every week, if you can, every shift, that's wonderful. I know that that's, you know, not always feasible, but at least every week here with your orientee, go into HealthStream, check out the checklist, make sure that we're just making progress day to day or week to week. For my newer preceptors, I'll make sure that you guys have access to it. So whenever you go onto HealthStream, what you guys will see when you go to your to-do list, you'll see an evaluate checklist hyperlink. And then I won't go all the way back, but then you will see the TSAM checklist, and then you will also see the HealthStream checklist that you guys were originally responsible for. Okay. If you guys are not seeing that hyperlink, please let me know so that I can escalate appropriately and get you guys access. If you are precepting in the SBU, I know a couple of you guys aren't here, are SBU nurses, you precept in the SBU, just going over different rules and expectations. This is a different environment. This is a totally different world for them outside of the ICUs. They should not be alone. That being said, you know, we do want to set expectation that, you know, there are some things that they can exude independence and exercise workload management. They shouldn't be completely, you know, it's not an observation, it's not a shadow shift, it's still an orientation shift. But I just want you guys to know that it's appropriate to see a mild regression. It's appropriate for them to not be doing things on their own and that they might be a little bit more timid or scared to work with this patient population. But things that they should be doing independently, they can initiate cares. So they're going to be going in with you. They're not going in alone, but they should be talking about the care plan, grabbing the materials. These are things they can do on their own, as well as making a care plan. Answering alarms, but never alone. You should be hot on their heels, getting into the room. They shouldn't be answering alarms alone in the SBU. Also looking for experiences. This is the perfect place to see an SBU admission, PIC placements, head ultrasounds, whatever. But just making sure that they're advocating for those, or, you know, even giving medications over the med line. That's a good one that they can see. Please no inline suction on IVH babies. There is a practice doll that last time I saw it was hanging out in the SBU, but it's an intubated doll with an inline suction. Have them practice on that doll, that baby. And as long as they are outside of that IVH bundle, they can do inline suction, but maybe have them do a practice on the doll first before they do it on the real baby. We do a skill station of practicing inline suction, but it's just nice for them to have a fresh practice right before they do it with you guys at bedside. Please avoid, this is a new little expectation we've added, but please avoid heel sticks on any babies that are less than 28 weeks. So this is, you know, in the SBU, we've just had an increased, not an increase, but we've had instances where there's been excessive bruising. These just shouldn't be the babies that they're practicing heel sticks on. So if they're less than 28 weeks, please don't have them practice heel sticks and lab draws. They can do central line lap draws, just not the heel sticks. And then please reach out if you precept in the SBU and you haven't taken the SBU class. This does happen, or you're not feeling comfortable precepting in there quite yet. You just took the class. Just send us an email. We will make a note to the unit supervisors to make sure that that doesn't happen to you. We want you to feel comfortable in there while you're teaching. Okay. Okay, so preceptor education. So just want you guys to be aware of the preceptor training revamp that we've gone through this year in 2025. So the levels of precepting and education that you can take, there's levels 1, 2, and 3 that all advocate for different RNs. So RNs 2 to RN 5. So a nice little just synopsis here. I'm happy to send this to you guys if you're interested on climbing the ladder and using your precepting hours towards advance. But if you're new to precepting, the first thing that you will do is take level 1 foundations of precepting, and you will do that via HealthStream. You'll register in the HealthStream catalog, and this will count for 2 contact hours and will be requirements to meet RN2 and RN3. Okay. And then we have levels 2, which those are those that have been precepting for at least 6 months and have taken the first level class. This is an in-person class that you will again register for in HealthStream. It's worth 2 contact hours, and it will be required if you are trying to achieve your RN4 in 2026. So that will be next year. Then level 3 is advanced precepting. This is coming soon in 2026, but that will be for any preceptors that have been precepting for more than a year. You have to take level 1 and level 2 first. This is via HealthStream, and you will register in HealthStream and will be required for RN5 when you apply for the advanced ladder next year. Okay. Any questions on the preceptor education or classes that we have, they've revamped for 2025? Okay, wonderful. All right, that's all I have for you guys. I really appreciate your time. I will be sure to send Saj that you guys were in attendance for an hour and a half so we can put that onto your time cards. I really appreciate your guys' time, sharing your questions, sharing your experiences. It's so helpful. And again, we appreciate all that you guys do. And we look forward to you guys precepting our winter fellowship group.
Thank you.
Bye, guys. Thank you.
Bye. Do you mind emailing this too?
The revamp?
Just like
This
the
one?
presentation.
The presentation, yeah. Yeah, well,
Okay.
you know what I'll actually send you also? I'm going to send the recording out to the group.
Okay.
Yeah. So
Sounds
thank
good.
you.
Thank you.
Bye, Abby.